Hi everyone, this is Phuong Tran from the University of Antwerp. Today I'm going to present to you our findings of the study on the household financial burden of non-communicable diseases in low and middle income countries. This is a systematic review. A co-author is Joseph Kazuikwe and senior author Christy Sidney Anderstedt. The chronic nature of non-communicable diseases and costs associated with long-term care can result in catastrophic health expenditure for the patient and their household, pushing them deeper into poverty and entrenching inequality in society. Despite the broadening literature on the financial burden caused by NCDs globally, most literature available is disease specific and from high income countries. There is a need to synthesize the costs incurred by patients or their households to enable comparisons between different diseases, settings, stages of the cascade of care, and types of costs. So, the objective of our study was to explore existing evidence on the financial burden of NCDs in low and middle income countries, specifically estimating the costs incurred by patients with NCDs and their households to inform the development of strategies to protect such households from catastrophic expenditure. This systematic review followed the PRISMA guidelines and registered with Prospero. Eligible studies published between 1st January 2000 to 7th May 2020 were systematically searched for in three databases including Medline, Embase, and Web of Science. A two-step process comprising of qualitative synthesis preceded by quantitative cost synthesis was followed. The mean costs are presented in 2018 US dollar. So, 51 articles were included, out of which 41 were selected for the quantitative cost analysis. Most of the studies were cross-sectional cost of illness studies, of which almost half focused on diabetes and/or conducted in Southeast Asia. The average total cost per year to a patient or household in low-middle income countries are as followed. For COPD, the amount is 7,386 US dollars. For cardiovascular disease, the amount is $6,055. For cancers, the cost is 3,303 US dollars. And finally, for diabetes, the cost is $1,017. Major evidence gaps were identified, including few eligible costing studies were found in low-income countries or on chronic obstructive pulmonary disease, and there was no eligible study on the cost of NCD prevention. There is also a lack of structured framework manifesting the cost at the different stages of the cascade of care for NCDs, making it difficult to capture a complete picture of the financial burden of NCDs to households across the cascade of care in low-income countries. In conclusion, the available evidence on costs revealed a large financial burden imposed on patients and households in seeking and receiving NCD care, and emphasizes the need for adequate and reliable social protection interventions to be implemented alongside universal health coverage. More empirical data on costs of specific NCDs are needed to identify the diseases and contexts where social protection interventions are needed the most. Rigorous and standardized methods of costing for NCDs will enable more reliable and comprehensive evidence of the economic burden of NCDs to patients and households in low and middle income countries. We would like to thank Susan Gustafson and Sabina Gilson of Karolinska Institutet Medical Library Research Consultation Group for their tremendous work of putting together the search string, and we would also like to thank Anastasia Lum from Karolinska Institute for her support in proofreading and editing this paper. Thank you very much for your attention.